either in person or virtually. Thank you, Alyssa. And it is a pleasure to get to know you all over the last 6 years that I've been working with the Maryland Primary Care Program and working with Mosaic Group. So Mosaic Group, we are a behavioral health consulting firm. I'm a licensed counselor and LCPC by trade, and specialize in working with individuals with alcohol and or substance use disorder and or severe mental health disorders. So I'll be talking a little bit today about something that is very common within your practice and something that was also a request to delve a little bit more into. These monthly webinars are free. They're something that is part of, because you are all part of the Maryland Primary Care, why can't I say that? Primary Care Program. We do offer additional education to providers and office staff. It is not all geared solely towards the providers. A lot of the information we hope will be beneficial to all of those that work within your practice as well. Some are geared more towards providers, others more towards perhaps MA or support staff. But by and large, we think that each of the webinars definitely has a lot of information that could be beneficial to everybody. So without further ado, last month we did discuss marijuana use and brief interventions because there is an ever-changing landscape to the legalization and usage and stigma and discussion around marijuana use. Today, we're shifting a little bit and we're going to focus on alcohol use. And so within primary care practices, we understand that when you all are screening patients, we know that most people use alcohol, right? About 60% of the population consumes alcohol to some degree, very common. We also know that most of the positive screens for SBIRT that you all encounter are related to alcohol use. And so we thought it would be helpful to discuss a little bit. I hear a lot from providers. I tell my patients all the time that they need to quit drinking, but they just don't want to quit. So today we're talking about, well, how can we help patients who aren't interested in or ready to quit? How can we navigate that conversation? So today's discussion is when quitting isn't the goal, navigating alcohol use in everyday practice. For those of you joining, please do make sure that you're adding your name, your role, and your practice within the chat. What else I would love to see within the chat is any suggestions for future webinars. So far we have, like I mentioned, discussed marijuana use and brief interventions. We've discussed SBIRT data and reporting, and we've discussed overview of SBIRT best practices. I'm trying to connect with somebody from MD Pure Medicare to include somebody to talk specifically about SBIRT billing. However, feel free to reach out to myself, Heather Raley, with any questions, thoughts about SBIRT billing. That is part of our fiscal year 2025 work with MDPCP. We offer technical assistance for SBIRT billing. And so please do reach out to us. We are happy to connect and help you optimize your revenue for SBIRT screening and intervention. However, if you have any future ideas for SBIRT and MOUD forums discussions, please put those in the chat also. All of the ideas that we have so far have come from your suggestions. So we want to hear from you and make sure your time is used wisely and with content and material that you find beneficial. All right, let's get moving. So today's objectives are to describe the benefits of addressing alcohol use in primary care and understanding how to apply motivational interviewing techniques for alcohol reduction, implementing harm reduction strategies for patients who are not ready to quit, but open to change, and recognizing strategies for overcoming resistance in brief interventions. So I want you to read some of these quotes, and you can either raise your hand, put in the chat, come off mute, which, if all of these sound familiar. I've been drinking like this for 30 years, and I'm not going to stop now. Or it's not like I'm drinking every day. I hear from a lot of younger patients. Well, my friends drink a lot more than I do. And I've tried those programs before, meaning treatment programs, but they don't work for me. Any of these jump out and sound familiar, or anything else that you hear typically among patients who may not be drinking very heavily every day, but are drinking at some moderate level? Okay, so thank you, Dr. Elb. So the not like I'm drinking every day is the biggest one. Absolutely, yep. Very common to hear that. There is the common misconception that only people who drink, quote unquote, every day have an alcohol problem. right? If I don't drink every day, then that means I do not struggle with alcohol use. Not necessarily true. As you all know, looking at the diagnostic criteria, there is nothing that alludes to quantity. Anything else that you hear a lot about, or a common response from patients when you try to bring up alcohol use? Nothing else coming to mind? All right, let's shift our thinking a little bit and think about either as a provider, maybe in your earlier days, because I know you aren't saying these things anymore, or from colleagues when you've worked elsewhere. Have we heard ourselves or other colleagues think or say these things? They've been drinking like this for 30 years. They're not going to stop now. I've heard that from plenty of providers as to why they don't discuss alcohol use with their Medicare population, who tend to be 65 and above. I've talked to them about it before and they won't quit. They've tried programs before and they didn't work. And it's not like they're drinking every day. Anything else that you've maybe overheard or been witness to from a healthcare perspective, where the healthcare providers have had, maybe misperceptions on alcohol use, or as to why they haven't brought up alcohol use to a certain population? Anybody want to come off mute and jump in? I do see we also have a variety of practices represented here, which is great, from all across the state, from Western Maryland, Eastern Maryland, Baltimore City, individuals working with FQHCs and small family practices. One thing we do notice that individuals who are coming to primary care, right, and screening positive for alcohol use, we know are often not individuals who are severely struggling with alcohol use disorder. Maybe they are, but by and large, those patients that are screening positive are not those patients that are drinking very heavily every day. That's not the majority of the population. So we're going to focus on those individuals who may not be drinking every day, but are perhaps drinking a little bit more than the recommended level. So we always kind of reset back looking at SBIRT, S being the screening, BI being the brief intervention, and RT being the referral to treatment. Again, today, we're going to focus on that BI, or brief intervention. So why address alcohol use in primary care? I'm not going to go spend too much time on this because I know that this is something that we've talked about at great length. But we know that primary care is often the only place where problematic alcohol use is identified early. In hospital emergency departments, they very often encounter individuals who are intoxicated or are really struggling with alcohol use disorder. But primary care has the opportunity to intervene early, and we know that that knowledge that may be presented to the patient in that early identification stage can change future outcomes. The potential health impacts. And so why address it in primary care? Patients are often presenting with chronic medical issues, high blood pressure, diabetes, comorbid psychiatric conditions, and they often exacerbate symptoms with alcohol. Medication interactions. We know that alcohol can reduce the effects of some medications for hypertension, antidepressants, for example, and they can increase the risk of GI bleeding with NSAIDs. They can potentiate opioids, sedatives, and antihistamine. So we know that a variety of very common medications that our patients may be taking could also be affected by alcohol use. So this is what we're going to talk a lot about today. My patients don't want to quit. So what can I do? How can I help them? There's a variety of ways in which we can help them. However, I thought it may be helpful first to hear from one of your providers. So Maryland primary care provider, Dr. Louis Silverstein, is an MD-PCP provider in Harford County. So he practices at Silverstein Medical, is the founder of Silverstein Medical, and at Havre de Grace, Maryland. And him and I had a wonderful conversation the other day, and he has, I think, a lot of really great insights and works with the Medicare population, works with a lot of individuals 60, 65 and above. And I felt could offer you some really helpful information as to how he intervenes with patients who may be drinking a little bit more within the healthy range. And then we'll revisit back to other ways that we can help those patients. So Christy, Dr. Silverstein, are you there?
Yes, good afternoon.
Hello, it's a pleasure to meet you. or to talk with you. If you wanted to take a second, just introduce yourself really quickly. And then, yes, I loved the other day specifically how you were telling the story of the value of screening patients. And you gave an example of a patient early in your career that hadn't been properly assessed for alcohol use. And it turns out that that was kind of an underlying issue. Maybe starting there would be a good.
Lou Silverstein. I'm been in practice, since 1983 in my hometown of Havre de Grace. The story was I had a lady early in my practice who was a social acquaintance, etc., and I couldn't get her blood pressure under control. And eventually I wound up using 6 different medicines. Then one day I find out she's hospitalized because she passed out. And it turns out she was a closet drinker and had decided to go cold turkey. And the alcohol had been supporting her blood pressure. And so without the alcohol, her pressure went to 0. Taught me a valuable lesson. And at that time, I think drinking among women was not as a hot topic as it is today. With the Espert, I'm reminded of cigarettes. And, you talk to people who were smoking cigarettes and I never, you would talk to them and then, I'm not giving it up, right? And so then I just would do a brief intervention of, are you ready to quit? And if they had problems, I would point out the problems and lessen. And eventually I started getting people to quit smoking. I do the same thing with Espert. And I mentioned that I play the salami game. You walk up to a person and you say, I'm starving, can I have your salami? And I'm more apt to hit you with it than to give you the salami. Well, I walk up and I say, I'd like a slice. You're a nice person. Can I have a slice? I do it every day. And by the end of the month, I have the whole salami. Same thing with people do, are you having some difficulties? Is your blood pressure not under control? We have abnormal liver enzymes. That's one thing. But the other thing is you pick up somebody who in the course of a weekend has 12 or 16 drinks according to them, and during the week don't do anything. And so, number one, I try to get them to measure their alcohol intake. If they make their own drinks, I have them use a shot glass so they get an idea of just what they're taking. And then secondly, I try to get them, even the ones that are having like 3 a day or 4 a day, I get them. And if it's beer, I'd say, what's the big hassle on that last beer if you switch over to an NA? The German NAs are very close to beer. And so I'll go ahead and recommend that. And I found that works with some people. And then when they eliminate one, then I work with them and get them to eliminate another. And, as far as they're willing to let me work with them to reduce the amount of intake, if not stop totally, because that may not be possible. You also have wine now that doesn't have alcohol. And, you just say, okay, you have your 2. How about switching to something with alcohol, but is very similar? And, or, okay, you like mixed drinks? Well, do your 2 mixed drinks and then switch to a soda with a twist of lime. And that way it looks like you're drinking, but you're not trying to reduce the amount that you're taking. But I found that it's not 100%, but I don't think anything in medicine is 100%. And it works better than nothing. And I've had some real successes with people who, it depends on how much trouble they've been having with alcohol to the degree they'll listen to you.
Thanks, Dr. Silverstein. I think a lot of those suggestions are extremely helpful, and I think a lot more acceptable to patients, right? Again, asking to quit is a huge undertaking, especially for somebody where alcohol has been a part of their social life, a part of their family life, for so long. However, on here, I noted the pacing or alternating drinks with water, but I think the NA beers or the NA beverages in general are a great option. There are far more now than there ever used to be. Our Medicare population may not even be familiar with what is out there now. I think a lot of people just think of the O'Douls and may or may not have tried that and liked that. But there's a lot more options out there now, the non-alcoholic seltzers and wine and other types of beer that really taste very much like an alcoholic beverage. And so alternating with an NA drink and increasing that is, I think, a much more digestible suggestion for a lot of the patients versus just asking them to quit. While we have Dr. Silverstein on, does anybody have any specific questions for him regarding discussions around alcohol use with patients? Look in the chat. All right. Well, thank you so much for your insights, Dr. Silverstein. And we may have another question for you in a bit, but I really appreciate kind of hearing from somebody who's working with patients in primary care day after day and what's been beneficial and, kind of where there may still be hurdles. One other thing that Dr. Silverstein had alluded to that I personally work with for a lot of my patients who are looking to reduce or eliminate their alcohol use is tracking. And so he had mentioned just sort of taking note of measuring the alcohol, because a lot of times people pour with a heavy hand and they think they're having a drink when really it equates to 2 to 3 drinks. I have come across an app called Sunnyside that I have no affiliation to. However, I've found it helpful for a few of my patients already who are just looking to have an awareness of how much they're drinking and use that to sort of track not only their drinks, but also their mood, their sleep, and see the correlation between perhaps their drinking and other aspects of their life. I've received really positive feedback from a couple of my patients that they found it really helpful. And it really has been part of the support system to help them reduce their alcohol use. Both of them at this time are not looking to eliminate, but rather reduce their alcohol use. However, if we're talking specifically for the Medicare population, using an app may be not as easily done as for some other populations. And so there was a patient that I also printed out a tracker. And so she was able to track physically each day how many drinks she used. I have another patient who uses a whiteboard, and he tracks in his room each day how many drinks he's had. And he aims to have 0 drinks on more days. And so while he's not necessarily cutting back the quantity on the days he's drinking, he's cutting back the number of days that he drinks. And so again, working with the patient and finding out what changes they would and would not be interested in. What things do they want to maintain and what things do they want to change? The other thing I often hear from providers is, well, I give them a list of AA meetings. And AA has definitely been beneficial and helpful and life-changing for a lot of people out there. I am not denying that. However, it is not the only way, and it is not the most effective way for somebody who is currently looking to reduce their alcohol use. AA has a very strong abstinence policy, and so for individuals who are looking to cut back or reduce, AA is usually not very accepting of that. And so, my fear, worry, my experience has been that people who are looking to cut back and experience AA realize very quickly that this is not for them and then are very unwilling to try something else. And so I would encourage you, if the patient's goal is reduction and not abstinence, then AA is not typically a recommendation that they'll follow through with. And then just some other kind of harm reduction tactics: avoid drinking on an empty stomach, ensuring a proper, healthier diet, all of these things that help us maintain a better health in order to be able to tolerate and metabolize the alcohol more effectively. Excuse me. So looking at MI strategies for alcohol use. So we'll look at some examples of open-ended questions, affirmations, reflective listening, and summarizing. So some open-ended questions, starting the conversation and asking a patient, what role does alcohol play in your life, without assuming or using the words, do you have a problem with alcohol, right? Really asking them, how does it play a role in your life? How does it come into the big picture of your life? And how do you feel about your current use, right? We saw some common examples before. Well, I don't drink every day. Or, it's not a problem because I don't drink every day. That's helpful to know offhand or upfront that that is the patient's opinion and feeling, because then you can guide the conversation appropriately following that. It allows the patient to lead the conversation also, and less likely that the patient will view it as a lecture, right? Well, my doctor talked to me again about not drinking, but instead a two-way conversation to really understand what are some things that might make you consider cutting back? A lot of patients have a, well, if this happened, then I would cut back. Well, what is that thing? What is it that they're fearful of? Or what do they think may happen or is likely to happen that they've already considered this? Also listening. A lot of times, we're helpers, right? We want to help people. We want to help them live a healthier, better life. And so we're sort of waiting for them to finish talking before jumping in with the suggestion, right? Making sure we're really hearing and understanding a patient rather than just jumping in with suggestions and as to what they should or should not be doing. Asking patients, what challenges have you faced when trying to change your use in the past, right? A lot of times if patients have experienced cutting back or quitting alcohol in the past, there may be a reason that they've returned to it or that they're not currently considering doing that again. And what do you see as the hardest part about making a change to your alcohol use, right? It very honestly is usually not for moderate drinkers, the fear of the withdrawal symptoms, but rather the fear of what they may be missing out on as part of the culture, the socialization, right? But as Dr. Silverstein suggested, that, with the NA options or going out and alternating with alcoholic and non-alcoholic beverages still allows the patient to be included and not miss out on the opportunities that they are worried about missing out on, an important part of their social lives. So some affirmations, understanding the patient's willingness to discuss, and it shows that you're not approaching with an agenda, right? So really, first, I always acknowledge to the patient that they made the decision to be honest about their alcohol or substance use, and it really takes a lot of courage to do that. So to thank them for sharing and being honest about their drinking. Allowing the patient's changes to be part of the plan and not setting expectations or stating suggestions early on, right? Rather than, have you ever thought about this? Or what about doing that? Early in the conversation, saying things like, you've been through a lot and you're still showing up and discussing a change, that shows a lot about your resilience. What might that change look like for you? Choosing to talk about this today is a positive move towards your health, and cutting back even a little is a meaningful step. Might that be something that you're open to, right? And so understanding that, again, it's not black and white. Patients don't need to quit to begin to see health benefits. And acknowledging and affirming any changes that they've already made. So maybe they haven't made a change to their alcohol use, but maybe they've made a change in that they're starting to go for walks more often. They are taking their medication regularly when they didn't before. They are cutting some salt out of their diet. They are checking their blood glucose levels 3 times a day. So whatever changes that they've already made that are health related, making sure that we're affirming and acknowledging those. Reflective listening. So we've talked about this before in past motivational interviewing trainings. This shows the patient that you're listening and following their lead and allowing the patient's words to guide their next steps rather than your words. So saying something reflective like, it sounds like alcohol has become one of your main tools for managing stress or tough emotions. Looking at the pros and cons, right? On one hand, alcohol or drinking makes you feel good in the moment, and on the other, it leaves you feeling worse physically or regretful afterwards. I hear that you're not interested in quitting, so acknowledging that this is okay, and I completely understand. Have you thought about what cutting back may look like? Again, we often hear patients immediately say, well, I'm not going to quit alcohol, right? Because they've been told by friends, family, doctor that they need to quit alcohol. However, there's other options versus just quitting. And then summarizing. So at the end of the conversation, really hearing the thoughts that are, allowing the patient to hear the thoughts and summarizing them, allowing them to reflect on their own words and recognizing any inconsistencies or concerns. So it naturally leads the conversation towards next steps and reflecting both reasons for and concerns about use. So something like, so far we've discussed how alcohol helps you relax after work, and you didn't realize it may be affecting your blood pressure. Does that sound right? Earlier, you mentioned that many of your friends drink much more and more often than you, and you're concerned about missing out on things if you stop drinking. but cutting back allows you to remain included. Does that sound right? We've covered a lot today. You've shared both positives and concerns about alcohol use. Where do you think you'd like to go from here? Right? Rather than a yes, no, would you like to cut down or not? You know, where would you like to go from here? What does a reasonable next step look like? And then resistance. We know that oftentimes when we come at patients with, you know, you need to quit drinking or here's a list of AA, they often get very resistant and defensive. Even just bringing up alcohol might bring forth some resistance or defensiveness. Really making sure that we're taking the time to listen to the patients, understanding their perspective in a non-judgmental way. So for example, it sounds like alcohol does help you relax and manage stress. And you're not sure if reducing would even be beneficial, right? And so acknowledging both the benefits and the disadvantages of alcohol use. Avoiding arguing, so resisting the urge or to challenge or debate their stance. So instead ask open-ended questions. What do you like about using alcohol? What are some things that you're less sure about? I have noticed that substance use in general, alcohol and drugs included, that patients are far more likely and open about what they don't like about the drug or alcohol when they've first been given the opportunity to discuss what they do like. What are the advantages, right? But it also helps us as clinicians to understand why the patient is doing this in the first place. What benefit does it serve? What gap or need is this filling? And we can then guide the conversation with that information. Again, overcoming resistance, emphasizing autonomy, so reinforcing that the change is their choice. I'm not telling you you need to do something, but instead you are choosing to make a change. It's completely up to you if and how you want to consider any next steps. My role is to provide information and support if you're interested. And affirming strengths and efforts, so recognizing even small positive steps. So it's a huge step to even consider a small change. I'm proud of you for that. I'm here to support any positive change, and even reducing from 4 to 2 drinks at each occasion will lead to positive changes. So, closing my portion, based on this quick overview, but hopefully helpful discussion, is there anything that jumped out at you that you may aim to do a little differently with patients using alcohol? Any insights that you've gained or any tidbits of information that you found helpful? You can either put in the chat or just come off mute.
Heather, this is Michelle Folsom down in
Hi.
Southern Maryland. Hi. Good overview and talk about this. One thing that I've found is that I also, I know that this might not be fantastic, but sometimes normalizing that there are other people that are struggling with the same issue allows people to say, okay, well, you know, it's a little less shame inducing, I guess. So I sort of normalize like, okay, you know, I've seen patients in the last couple of weeks that say the same thing as you. We discussed these other options that they may have. What about things that you might want to do? So I don't know. I've actually found that works also with so many different non substance use or behavioral health things, even things like incontinence, which has a large stigma and shame around it. So normalizing some of the facts that other people are dealing with the same thing, that this is not something that they're dealing with alone or that is unique to them. So that's just my 2 cents from what I see over here.
Absolutely. I think that's a great suggestion, right? And helping patients understand that they aren't alone, right? And here's what's worked for some other people, right? Because they may be with the stigma and shame that sort of surrounds alcohol or substance use. They are very likely not open with many others about their concerns or their goals to cut down. And so by showing that there are plenty of other people out there, I think is extremely helpful in allowing them to feel and understand that they're in a safe space, that they can talk with you about it because plenty of other people have already talked to you about it. They're not the first person that's experiencing this problem. And so you're less likely to judge them for it, which I know is a fear for many people. Any other thoughts or input? Or suggestions or things that you found helpful for patients with using moderate or risky alcohol use? Oh, great. So we have in the chat, Tanya noted that when calling patients for follow-up to see if they have tested positive during screening, I'll listen to them and acknowledge how they want to proceed to guide them to the best outcome for their overall health instead of automatically suggesting treatment. Absolutely. I think that word treatment in general, I always try to avoid it, especially in a primary care setting, because a lot of people who don't have experience with alcohol or substance use treatment hear the word treatment and think, I can't go somewhere for 30 days, or I don't think I need to go somewhere for 30 days, right? A lot of people associate treatment with inpatient. And I didn't realize that until I started working in healthcare and realized that that is kind of the general thought or assumption that when somebody says treatment, they mean inpatient for 30 days. However, I usually use the term something like, have you ever thought about talking to somebody about your alcohol use or seeing a counselor to discuss your alcohol use, right? Because there are, as we know, a variety of levels of care. And many patients, especially in like that moderate risk alcohol use, are very likely drinking at that moderately risky level, perhaps in response to other medical or co-occurring mental health issues, right? And so by talking with a counselor about both their alcohol and co-occurring chronic illnesses, really can lead to some benefit without the need of having to go inpatient. And so I think that's a great suggestion, really, again, reflecting back what you're hearing from the patient and asking them how they would like to proceed, and understanding that patients may need that description of the variety of different levels of care, that there are outpatient counselors that you can just meet with once a week or a couple times a week or less than that. That might be a good start in the right direction for change. All right, so a reminder to anybody who has not yet to please sign in the chat with your name, your role, and your practice. And also happy to take some suggestions for anybody who would like to put a suggestion in the chat for a future, or shoot me an email for a future webinar. We have once a month, typically the third Tuesday of the month. And so as always, we usually leave the second half open for any questions regarding medications for opiate use disorder, any questions regarding the SBIRT process in general. And also, as I noted earlier, we are, one of our goals identified in fiscal year 25 in our work with MVPCP is to help practices not only with SBIRT billing, but also with adolescent screening. So if you are a practice that sees adolescents, most EMRs have a screening tool already built within them. And the goal is for adolescents to be screened once a year using a validated tool for alcohol or substance use. And so, I'm happy to talk briefly about that, or set up a separate time where we can talk specifically about your practice with your EMR and adolescent screening and or SBIRT billing or anything else. But I will remain on here until 1 o'clock. So if anybody has any questions, thoughts, anything you'd like to bring up, I am happy to help in any way I can. Otherwise, you are free to go.
Hello, Hannah.
Hi, Dr. Park. How are you?
Good. How are you?
Good, good.
So